The study accrued about 123 patients through the United States through our network, and the primary endpoint was met. So it was a positive study. The difference was pretty impressive between the two arms, almost double, a little bit less than double, and was statistically significant. So essentially, the study was a positive study suggesting that the dose escalation strategy from 80 to 120 to 160 was superior in that aspect to the 160 milligrams. What was interesting and intriguing was also looking at the secondary endpoint of survival. With the dose escalation strategy, the survival was 9 months versus the standard dose strategy was 6 months. Now 6 months is the number we see also incorrect with 160 milligrams. So that's what you would expect from regorafenib and from some other drugs in the same space. So TAS-102 and other agents produce typically a survival close to 6 months. So we're very pleasantly surprised to see that the survival with the dose escalation strategy sat on top was 9 months, so 3 months superior, although it was not statistically significant. But if you look at those curves separate very nicely from the beginning and stay all the way through beyond a year. So that got us excited. So there was a secondary endpoint that was at least favorable, and then the PFS was a little bit better. The toxicity profile was slightly improved with the dose escalation strategy because everyone gets on the same drug ultimately. And another finding that was very intriguing from this study is the quality of life. The quality of life of patients when you use the dose escalating strategy from 80 to 120 to 160 was not compromised when you use the dose escalation strategy. So it was a straight line. Whereby with the higher dose, with 160, with the standard dose, at 2 weeks you see a drop in the quality of life that readjusts as you readjust for the dose of the medication. So that difference was consistent across every parameter that was included in the quality of life. So ultimately, when you put all this together, it sounds that a dose escalation strategy may confer a larger benefit than actually starting with 160, and could perhaps change the standard of how we do things. Now certainly the one limitation about this study, it's a phase 2 randomized study, it's not a phase 3 randomized study, but it was powered enough to understand the question. I think it creates a new strategy for our patients when physicians decide to start with a lower dose. In my own practice, that's the strategy now I'm going to adopt based on redose, meaning every patient I'm going to see in clinic is going to start at 80, comes back in a week, goes to 120, comes back in another week, if still tolerable, goes to 160.